Welcome everyone, and thank you so much for attending our November webinar, Navigating the Diagnosis and Management of Diabetic Nerve Pain. My name is Nicole Hemingway, and I am the CEO of the US Pain Foundation. So before we dive in to our presentation tonight, I wanted to just go through a quick rundown of what to expect this evening. After discussing a few general items, we'll start by looking at the efforts of US Pain Foundation this month, our November campaign, as we aim to get to know DPN, or diabetic peripheral neuropathy. I will then introduce our presenter, Dr. Priyanka Singla, who will be discussing the diagnostic process for diabetic nerve pain, management options, and the hope fueled by ongoing research. Please note that the information provided tonight is educational purposes only. Also, the views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. We will answer questions at the end of the webinar, but you can submit questions throughout the entire presentation. Please type in your questions using the Q&A icon at the bottom of your screen. And finally, know that this webinar is being recorded, so you will be able to watch it again at a later date through our website. US Pain Foundation designates November as KNOWvember. It's our annual educational campaign spotlighting important pain-related topics. And this year, our focus is on diabetic nerve pain, or diabetic peripheral neuropathy, or DPN. We would like to express our sincere gratitude to our sponsors of this November initiative, which is Veritas Pharma and Vertex Pharmaceuticals. Please know that this campaign was developed independently, but we deeply appreciate the contribution so that we can continue to raise awareness and support around very important initiatives. This year, through our DPN, No DPN initiative, we are focusing on raising awareness about the complexities of diabetes-related pain, emphasizing the importance of early detection and connecting people to the resources and care they need to improve health outcomes. Our goal is to raise awareness about the profound and often life-changing impact of diabetic nerve pain and the potential complications that can arise if left untreated. We want to raise awareness about how to recognize the early signs of DPN to enable timely intervention, which may help prevent nerve damage and significantly improve quality of life. We want to talk about specialized care options, including medications, treatments, lifestyle changes, and preventative strategies to manage and reduce symptoms. And finally, we want to work on how we can connect with reliable resources and hear firsthand experiences from others with DPN to build a supportive community and inspire hope. We invite you to get involved throughout our month, November, looking at how we can better get to know DPN. And ways that you can do so is downloading our infographic on foot care, reading and sharing our November articles, registering for online future events, liking and commenting and sharing on all of our social media posts, and using the hashtag NoDPN and November in all your November posts. So with that, I have the distinct privilege of introducing our guest presenter, Dr. Priyanka Singla. Dr. Singla is an assistant professor of anesthesiology and pain medicine at the University of Virginia School of Medicine. Her clinical expertise spans both chronic and acute pain management and neuroanesthesiology, with a strong research focus on neuropathic pain, perioperative outcomes, and neuromodulation. She is an active member of several prominent committees, including those of the American Academy of Pain Medicine, the American Society of Anesthesiology, and the American Society of Regional Anesthesia and Pain Medicine. Dr. Singla also serves as a vice chair of the Education Committee for the American Academy of Pain Medicine and as an associate editor for ASRA Pain Medicine News. She has authored and co-authored numerous peer-reviewed scientific publications and is sought-after speaker at prestigious events, including the World Congress on Regional Anesthesia and Pain Medicine at the American Society of Anesthesiology. Dr. Singla received her medical degree from NP Shah Medical College in India, followed by a residency in anesthesiology. She joined the University of Virginia in 2016 as a research associate and completed both a fellowship in pain management and a general surgery internship, in addition to anesthesiology residency training at UVA. Notably, she was the first pain physician in Virginia to implant a groundbreaking neurostimulation device for restorative therapy in low back pain. Dr. Singla resides in Charlottesville area with her family and enjoys traveling in her spare time. Dr. Singla, we are so thrilled and excited to have you here with us to talk all about DPN and diabetic peripheral neuropathy. And so now I'm going to turn it over to you. Thank you so much for being here.
It's an honor to be here. Thank you so much to US Pain Foundation for inviting me to talk to patients and their loved ones about diabetic peripheral neuropathy. It is one of the topics that I'm passionate about because one of my family members suffers from it. So there is personal investment in the betterment of patients that suffer from this disease. Next slide, please. I don't have any disclosures. Next slide, please. So today we're going to learn about the incidence and healthcare burden of painful diabetic neuropathy. Diabetic neuropathy, DPN, is per se is a term that describes only the diabetic peripheral neuropathy, but when P is added to it, that adds the painful part of it, that is a huge life care burden in the lives of a number of patients. We're going to discuss the pathophysiology, the diagnosis and management, as well as the pain management approaches, which include oral medications, topicals, nutraceuticals, and neuromodulation. Next slide, please. Diabetes is probably one of the more prevalent chronic conditions that affects all the people across various continents. About 34 million adults in the United States have diabetes, and diabetic peripheral neuropathy is present in about 30 to 50% of the patients that suffer from diabetes. And about half of those patients have the painful side of the peripheral neuropathy, which is called the painful diabetic peripheral neuropathy. The annual cost of this disease for us in the United States is about 10 billion. So as you can see from the numbers, it's huge, and that has a huge impact on the lives of the patients as well as the healthcare system. Next slide, please. This is a cartoon that just represents the nerve cells that kind of carry the signals from the periphery to the brain. It's just a cartoon that embodies that kind of transmission of the pathways. The alteration of the chemical structure of the neuron due to blood sugar, which leads to change in the proteins, leads to the various forms of diabetic neuropathy. Next slide, please. So when we talk about diabetic neuropathy, it is the peripheral neuropathy. That means the numbness, tingling, burning that is felt in the arms and feet. It is typically in a glove and stocking distribution, is how is described in the medical literature, that it starts in the feet and it involves the kind of distal part of the legs, and then it creeps up into the hands. And where you would classically wear the gloves and the socks, that part of the body has tingling, numbness, and burning along with pain. The other kind of neuropathy that the diabetes patients are kind of suffer from is the autonomic neuropathy. And that is generally feeling full after meals, vomiting, nausea, diarrhea, constipation, decrease in blood pressure when we stand up, that is called orthostatic hypotension. These are the symptoms when a patient suffers from autonomic neuropathy. The third type is the proximal neuropathy, which is also called diabetic polyradiculopathy, which means weakness in thighs and buttocks. It also leads to pain in hips and buttocks. But characteristically, it's not the kind of peripheral neuropathy that is associated with diabetes. And the fourth type is when a particular nerve is affected. It is focal. That means, pain is in distribution of one nerve, such as eye pain, double vision, chest pain, Bell's palsy, that is paralysis on one side of the face. Most common is the diabetic peripheral neuropathy, and that is what we're going to focus on today when we talk about diabetic peripheral neuropathy in terms of, tingling, numbness in your feet and hands, along with burning and pain. This is mostly a clinical diagnosis. If it is in glove stocking distribution, it can be diagnosed by special tests, which are called the nerve conduction tests, where different needles are placed along the pathway of the nerves, and the interventional physician who's doing this test then sees how well the nerve is functioning. Another test that can confirm diabetic neuropathy is called a muscle biopsy, or it is where they look at the density or how many nerve fibers endings are there in a particular skin biopsy. But most of the times, diabetic neuropathy is diagnosed based on symptoms when a patient has diabetes. Next slide, please. So when we talk about treating diabetic neuropathy, there are a number of algorithms. First and foremost is suspicion of diabetic neuropathy based on history and exam. Then confirmation can be based on objective tests that we talked about, or just clinical diagnosis is sufficient. We don't need to confirm it on tests. Of course, if there is a question that there are non-diabetic causes of neuropathy, which are present in about 10% of patients that suffer from diabetes, then of course, other objective tests can be used to confirm that. Like, for example, a patient who has diabetes can have sciatica, which is basically pinching of nerves in your spine. But however, sometimes it's difficult to differentiate the symptoms of sciatica from the tingling and burning that you get from diabetes. So in that case, MRI scan of the back or a nerve conduction study can be helpful to diagnose that. Along with diabetes, the other common causes of neuropathy include vitamin deficiency, such as vitamin B12 deficiency, alcohol, trauma, malignancy, as well as malignancy that means cancer, as well as chemotherapy agents, which are medicines that are used to treat cancer, can also cause neuropathy. Once a patient is diagnosed with neuropathy, then there are two ways in which we go about treating that patient. One is symptomatic management. Symptoms means what you are describing, that is pain. So we start medications that help with that pain. And the other part is preventative, that is maintaining the general health of the patient in terms of exercise, glucose control, which we're going to see in a second. Next slide, please. So this slide is one of the rubric or algorithms that I put it as an example to show how we treat diabetes by different ways. The conservative measures are physical therapy that can be, weight-bearing exercises, Tai Chi, massage therapy. Then optimization of blood glucose, that is, how well blood glucose is controlled. That is one part of the puzzle. Managing other health conditions that affect the general health as well as the nerve health, along with minimally invasive treatments such as acupuncture and TENS. Acupuncture is a specific therapy that there are specialists who are certified in doing acupuncture, and there is some evidence that it does help in diabetic peripheral neuropathy. And TENS is basically a machine that kind of we put in, that you can buy over the counter, that you put in the distribution of your pain, and it gives little tiny electrical signals that block the pain signals. We call it, it's a very famous pain theory. We call it the gate control theory, based on which it works. Then come the medication part of it. The first line treatment agents are generally pregabalin, which is also known as Lyrica, duloxetine, which is also known as Cymbalta, and gabapentin, which is also used. The medications in which there is a star above the medication, those are actually the FDA-approved medications that the FDA has approved for treatment of painful diabetic peripheral neuropathy. The second line agents are mostly the antidepressants. It is either venlafaxine or amitriptyline. Tapentadol, which is a partial opioid, 8% capsaicin patch, lidocaine patch, and then the third and fourth line agents are tramadol opioids, and then IV agents, which are basically given through the IV when you are admitted to the hospital, such as lidocaine and ketamine. Then there are some interventional kind of therapies, which are devices that can be used to control pain. The most common one used for diabetic peripheral neuropathy is spinal cord stimulation. The SCS stands for spinal cord stimulators. The description of tonic and 10 kilohertz is just the waveform. There's an update to this that the tonic has also been approved by the FDA. So basically, the difference between the tonic and 10 kilohertz is in 10 kilohertz, the patient doesn't feel the stimulation. In tonic, the patient feels the stimulation. And I'll explain later on what does spinal cord stimulator mean and how does it help. Then there are other devices, other waveforms available as to how the SCS is used to stimulate the spine, peripheral nerve stimulators, and finally, the intrathecal pumps. Very rarely those are used as well. Ziconotide is probably one of the few medications that has been approved for neuropathic pain in that intrathecal pump implantation. Next slide, please. So control of glucose. In studies, it has been shown that control of glucose in patients who suffer from type 1 diabetes, that is traditionally patients who require insulin from the get-go, patients who develop diabetes at a young age, and there's an autoimmune component to their diabetes. Those patients with glycemic control, that is good control of blood glucose, have better outcomes for diabetic peripheral neuropathy as compared to type 2 diabetes, that is later in onset age. We start with oral diabetic medications, and there is insulin resistance where your body is making insulin, but insulin is not able to act on the tissues along the body in order to kind of process that blood sugar. There is also focus on multiple other targets, such as normalizing the lipids or cholesterol, blood pressure, weight, along with lifestyle modifications to achieve a healthy diet and regular exercise. Exercise is one of the therapies that has been targeted and studied, and it was shown that patients who have a structured kind of exercise regimen did better with patients who were just given direction. Next slide, please. Foot care is a very important part of global care of a patient that is suffering from diabetes. About a quarter of patients with diabetes will end up with a foot ulcer, and that is because of nerve damage, patients are not able to feel if something nicked the bottom of the foot. So plantar callus formation is just the hardening of the bottom part of the sole. And when you have something touching it causing injury, the patient is not able to feel that. And on top of it, when there is uncontrolled blood sugar, which is food for bacteria, that develops into ulcer. And because of poor healing conditions, that ulcer doesn't heal and it progresses, which leads to kind of the classic diabetic ulceration, which is a very common cause of amputation. So taking care of the foot is very important in a diabetic patient to for preventing foot ulceration. The next slide, please, I took it from the US Pain Foundation website. It has the steps that helps in kind of taking care, 6 steps to healthy feet. Like, look at your feet every day, wear shoes around the house so that you accidentally don't bump into anything and cause injury. Wear the right shoes. They should be tight. They should not be too tight fitting. They should not be too loose fitting. Check the temperature of your bath water with your elbow so that you don't accidentally cause burns. Stay on top of the foot hygiene, that if there is any ingrown toenail or anything of that needs to be taken care of, it is taken care of. And get help with nail care. Next slide, please. So vitamin B12 deficiency is in itself a cause of neuropathy. For patients who have diabetes are put on metformin mostly as a first-line medicine, and metformin decreases the absorption of vitamin B12. So it is very important to screen for B12 deficiency, especially if diabetic neuropathy is not typical, or if it worsens suddenly, and if the patient is taking metformin. So that is another thing that is an alternative cause that we need to keep in mind as physicians when we are assessing a patient with diabetic neuropathy. Next slide, please. Coming to the oral medications, the 3 big classes of medicines that are used to treat neuropathy are antidepressants. They come in 2 flavors, tricyclic antidepressants and serotonin norepinephrine reuptake inhibitors. Basically, these words are describing the class of medicine. And we'll talk about the specific examples and how they differ. Anti-seizure medicines, which are also called anticonvulsants, such as gabapentin and pregabalin. And the last class is opioids, that includes tramadol and tapentadol. Next slide, please. So anti-seizure medicine, or pregabalin, this is one of the FDA-approved therapy for diabetic neuropathy. The starting dose is generally 75 to 150 milligrams per day, and it's titrated in increments of 75 milligrams per day every 3 to 7 days based on how the patient is responding. Again, this is suggested and is individualized based on how the patient is doing, and it's not a set kind of rule. So it is very important to talk to your physician so that the physician and you can come up together mutually with the regimen that can help you. The total daily dose of 300 milligrams is the maximum dose that is approved by FDA for diabetes-associated neuropathic pain. However, there are other conditions other than diabetes neuropathy in which doses more than 300 milligrams are used for this particular medication to treat patients. The side effects are probably the most limiting part of using this medicine, and they include dizziness, grogginess, peripheral edema, and weight gain. So especially in patients who are trying to lose weight in order to help better control their diabetes, this is one of the medicines that we are very careful starting. However, weight gain does not happen with every patient. It is seen in approximately 2 to 4% of the trials that clinically meaningful weight gain happened. But however, in my clinical experience, it does not happen very commonly. It does happen, but it's not that every patient gains weight and needs to be taken off this medicine. Next slide, please. So the second medicine that is very commonly used to treat this condition is called duloxetine or Cymbalta. It's an antidepressant. It was originally developed as an antidepressant, but then it is now used more for pain than depression. So when I discuss this with my patient, I do tell them that originally it was discussed as an antidepressant, but I am using it for pain. I am not using it for depression, because this is a very common misconception that I put my patient on an antidepressant and they are upset that I'm not depressed. Yes, I 100% agree. And it's not, my expertise to treat depression. I use it for pain. The typical doses are 60 milligrams per day to 60 milligrams 2 times a day. The common side effects are GI discomfort, nausea, vomiting. GI discomfort means gastrointestinal issues, fatigue, decreased libido. These side effects typically stabilize in 3 to 4 weeks. However, there is a risk of drug interactions with this medicine, along with the risk of serotonin syndrome. There is also a black box warning from the FDA for duloxetine regarding the risk of suicide in patients less than 24 years of age. Next slide, please. Venlafaxine. This is another medicine of the same family as duloxetine. It is the dose that is used in neuropathy is 37.5 milligram, which is titrated to a larger dose of 75 to 225 milligrams daily. The maximum reduction in the larger study for this group was noted at week 6, and the side effects are similar: nausea, somnolence, which is grogginess, dizziness, insomnia, sexual dysfunction, increased blood pressure and heart rate, and it can also exacerbate restless leg syndrome. Next slide, please. Tricyclic antidepressants. This is a second class of antidepressants that have been used to treat neuropathy. The basic advantage of this class of medicine is that it is cheap and effective. However, the biggest limiting effect, that kind of biggest limitation, is the side effects. There are significant side effects with this medication class, and death has been reported in overdose. There are a number of drug interactions. So we need to be very careful starting these medicines. The side effects that are noted are basically because of the effect of this class of medicine on the autonomic nervous system. So kind of urinary complaints, heart rate issues, those are the kind of issues because of which this class is not very commonly tolerated. The therapeutic effect is seen in less than 6 weeks, and typically lower doses are needed than needed for depression. Next slide, please. This is kind of a table that shows where, in which comorbidity, which medicine is favored, and in which comorbidity kind of summarizes which medicine is avoided. However, this is a conversation between the patient and a physician, and it should be done on a case-by-case basis after discussion. Next slide, please. So topical agents, those are kind of, patches or creams that are applied to the feet, primarily to help with pain relief. Lidocaine 4% is available over the counter. Now, since 4% is available, most insurances have stopped covering the 5% patch. There is limited evidence that it does help. The overall benefit of this class of medicine is that the side effects are typically less as compared to when you take any medicine by mouth. So these medications are typically well tolerated with minimal side effects. Capsaicin is another one. It is available in 2 flavors. Over the counter is a very weak combination. I think it's 0.1 or 0.02%, something like that. But the 8% formulation is the patch that is used in a doctor's office that has shown promise for painful diabetic neuropathy and has been approved by FDA for treatment. Next slide, please. So coming, the capsaicin 8% topical patch, it is given by a healthcare provider in clinic. It is a single application where I'll show you the steps, basically what to expect. It can be repeated every 3 months for patients who get partial relief or temporary relief after the first application. And the side effects are limited to redness, which is erythema, pain, and very rarely post-application sensory loss. Next slide, please. So basically what happens is that once, this is a schematic that shows what happens when we use this patch. It is exclusively approved only for the feet. So it is not even used on the legs for diabetic neuropathy, just the feet. When we identify a patient as being appropriate for this therapy, the patient is booked for the procedure, the feet are cleaned, and then there is, if the patient has sensation on the feet, then a numbing agent is applied and it is left for 30 minutes to an hour. And then the feet are cleaned off. And then the patch is applied and left on for 30 minutes. And after that, the patch is removed and the feet are cleansed. Like I said, burning is probably the most common complaint that I see with this application, which is temporary and goes away. However, it can be distressing. So again, the therapy needs to be individualized to the patient. Next slide, please. It has been shown that, in healthy patients, there was a decrease in the nerve fiber density, which kind of regenerated after 12 weeks, and full recovery was made in about 24 weeks. This was done in healthy volunteers. I believe there was a study that was recently presented at the IASP conference that simulated this in patients with diabetes. So it does help with pain relief and nerve fiber regeneration. That probably is one of the only therapies that does affect the density of the nerve fibers, or how many nerve fibers do you have in a patch of skin. Next slide, please. So nutraceuticals, these are typically not regulated. I call them nerve vitamins, kind of, substances that help in general health of the nerve. These are available over the counter. They're available in natural natural food stores. Two of them have been kind of quoted in literature repeatedly. The first one is alpha lipoic acid. Next slide, please. That is probably the most well-researched nutrient. It decreases the oxidative stress. What that means is in diabetes, there is abundant oxidation, which kind of, these are reactive radicals that lead to the nerve damage. So, in a dose of 300 to 600 milligram, alpha lipoic acid has shown positive effects on the nerve conduction velocity. That is the speed at which the nerve fibers conduct the signals, transmit the signals. There is the Nathan-1 study that measured the effects of alpha lipoic acid after 4 years and showed improvement in mild to moderate diabetic neuropathy. Side effects are generally rare with this this kind of nutrient, but may include insomnia, fatigue, diarrhea, and skin rash. This is not, however, medically regulated and is available over the counter. Next slide, please. Benfotiamine is a synthetic form of vitamin B1. There is some evidence that when it was compared to patients who had neuropathy versus patients who were given placebo, that there was improvement in the kind of score that measures neuropathy. However, there is no evidence, conclusive evidence, about how well it works in patients with diabetic neuropathy. Next slide, please. So to summarize, the FDA-approved therapies for painful diabetic neuropathy include duloxetine, pregabalin, extended-release tapentol, capsaicin 8% topical in-office treatment, and spinal cord stimulation. I will add a word here about opioids, such as tapentadol and tramadol, although they are kind of used. However, the longitudinal risk of the various risks of opioids, including addiction, constipation, tolerance, probably outweigh potential benefit for long-term use. Next slide, please. So spinal cord stimulation, this is kind of a newer technology that has been used for diabetes in the past 10 years. It is FDA approved for treatment of painful diabetic neuropathy. It is basically threading two epidural kind of, two leads, which if you think about, epidural catheters that women get for labor, we basically thread it up the spine, and it provides tiny electric signals or stimulation to the spinal cord that then blocks off the painful signals from the hands and feet. It is site-specific. Spinal cord stimulators for lower, for feet are placed at a different level in the spine, and the one for hands are placed at different level in the spine. This is mostly in context of the feet that I'm talking about, the use of spinal cord stimulators. And it has shown promising results. Next slide, please. So it was approved for painful diabetic neuropathy in 2021. And then, there are various waveforms. That is basically the electrical, kind of engineering and plumbing, how the spinal cord stimulator gives energy to the spine. Basically, that defines whether it's conventional tonic, that is continuous signal, patient is able to feel the stimulus, and it's called paresthesia based therapy, where the patient feels the tingling kind of buzzing sensation. Then the other one is high frequency, which is the 10 kilohertz. That was actually the first one to be approved for this kind of disease process. And the third one is burst, which is another waveform. Next, please. So this slide kind of explains the concept of spinal cord stimulator. Like I said, it is based on the gate control theory, like the TENS unit, where stimulating the large nerve fibers kind of inhibits the input from the small pain fibers. Next slide, please. So evidence so far for spinal cord stimulator, there are 4 randomized controlled trials. Randomized controlled trials are the best evidence that we have in research, where patients are randomized to one or the 2 groups, and then they compare the efficacy. And most of the times, the patient and the investigator are not aware of which group they are in to eliminate bias. There are 3 randomized controlled trials for the tonic or the paresthesia based, where the patient can feel the stimulus, and 1 for high frequency, which is the 10 kilohertz, where the patient cannot feel the stimulus. There are 7 prospective cohort studies, where again, there are 2 groups of patients and compare outcomes in those group of patients. Next slide, please. So this was a landmark trial that led to the FDA approving spinal cord stimulator for peripheral neuropathy, where there was a group of conventional management, and there was a group that got the spinal cord stimulator. And as you can see from the graph, the VAS score is the pain score. That is what your physician asks you when you go to their office, that rate your pain from 0 to 10, with 10 being no pain, and with 0 being no pain, and 10 being the worst pain of your life. So you can see CMM is the conventional medical management that includes good blood sugar control. With the bottom one is the spinal cord stimulator, and you can see that the spinal cord stimulation, it did provide good relief, which was sustained. The 24-month data for this trial was published recently, and that also kind of followed the trend. One of the things that was done in this trial was that the patients who were randomized to conventional medical management were allowed to cross over to the spinal cord stimulator, and kind of this decrease in pain trajectory was maintained in patients who switched over from conventional medical management to spinal cord stimulator. So kind of impressive results. And of course, it was landmark, and the FDA took note of it and approved spinal cord stimulators for diabetic peripheral neuropathy. Next slide, please. Pancreas transplantation, that is another area that is focus of research. The theory behind it is it restores insulin secretion. That is probably one of the only curative treatments for diabetes. And there have been studies that have shown that there have been different lengths of time for improvement in symptoms of diabetic peripheral neuropathy who have been treated with pancreas transplantation. Of course, the limitation is restricted and unpredictable availability of suitable organs, complications of the surgery, and risks of lifelong immunosuppression. So there is a lot that is happening in this realm. Like in the past 3 years, spinal cord stimulator is the big one that made a change. But of course, there are granular details as to which patient is appropriate for that therapy. There are, guidelines which need to be followed, whether a patient is a candidate or not, that have been laid down by various societies. So it is very important to discuss with your physician what your options are. And then, there are some genetic things that are underway. So there's a lot of hope for future that I would say for painful diabetic neuropathy. Next slide, please. And with that, we come to the summary. It is a highly prevalent disabling condition. The FDA-approved treatments include oral medications, capsaicin 8% topical in-office treatment, spinal cord stimulation. The selection of appropriate therapy depends on the comorbidities, potential adverse effects, and drug interactions in an individual patient. And I would recommend that you consult your healthcare provider for options if you're suffering from this condition. And then in the end are my references for this talk. Please, I'll be happy to take any questions.
Thank you so much, Dr. Singla. I mean, this was such a comprehensive presentation that I really think helped advance our understanding of DPN. So speaking of understanding, I do have a couple of questions that have come through the Q&A, as well as some that my team has been sending to me that people have been asking. So for those of you tuning in right now, if you do have a question, please submit it in the Q&A and we'll get to as many as possible. But I think I wanted to start out with the fact that one of the things that was so stunning to me is that there's only a handful of actual FDA-approved treatment options right now for DPN. And I know you talked a little bit about some of the newer findings, but is more research being done? And are there other things that might be coming in the pipeline, really to give individuals more hope about what's out there for them if they are living with DPN?
Absolutely. Like, going back to 3 years ago, capsaicin, spinal cord stimulator, those two are the big ones that got approved. So, in the recent, I cannot think of any other disease process in pain that has led to approval of two, therapies by FDA for a particular disease process. And again, it's not just spinal cord stimulator, the high frequency one. Subsequently, the tonic form was approved as well, the paresthesia-based. So, now they're studying other waveforms to see if they help patients more. And then there are other neuromodulation techniques that are being studied, such as dorsal root ganglion stimulator, peripheral nerve stimulator. We don't have much data about these conditions, about these devices, but they are in works, and I'm hopeful that next time we meet, we'll have more data on more therapies.
Great, thank you. But there are things coming in the pipeline, so yes, that is always helpful as well for people living with DPN. You brought up talking to your healthcare provider, and actually one of the questions that we did receive was, what providers should you be seeing if you are living with diabetes or DPN, or any provider is the one to go to talk about your treatment options?
So I would start with the provider who's managing your diabetes. A pain physician typically requires a referral from somebody, but it again also depends on where you're living and what the situation with that particular, local pain clinic is. I know some pain clinics do accept self-referrals, but the best place to start with is your primary care physician or your endocrinologist. Or if you have a pain provider, then absolutely reach out to them. They'll be happy to help you.
Great, thank you. Can people have more than one type of diabetic neuropathy? So for instance, could somebody have both DPN and then autonomic neuropathy at the same time?
Yes, absolutely. That's a very good question. Yes, patients can have more than one type of diabetic neuropathy. And it is common as diabetes progresses to, we think about gastroparesis, right? Gastroparesis is when the gut slows down and diabetic patients are prone to throwing up. they're not able to, they have to eat smaller foods and stuff like that. So that is an indication of autonomic neuropathy. Plus, you have burning in feet, hands and feet. That is the classic diabetic peripheral neuropathy. So yes, these can coexist.
Okay, thank you. Another question is, does DPN always spread to other extremities? I've had it personally for 12 years. This is the question, and it's only affected my feet, or does it eventually spread?
Nobody can predict the progression. It could be slow. It is possible that you feel it only in your feet, but there is a potential to spread.
Okay. Sorry, there's a lot of questions coming in. I'm trying to read through some of them really quickly. Well, this one's interesting. Now that pain has been more accepted by the medical community as a disease state, and not just as a symptom, how do you see this impacting individuals with DPN or work on DPN?
The biggest evidence of that is development of spinal cord stimulator. It's a disease process. So yes, it is being taken seriously. There are therapies in works that actually are looking to see if there is something that would reverse this. Unfortunately, there is not much out there that would suggest reversal of diabetic peripheral neuropathy. Even robust glucose control, intensive glucose control has its own side effects. And one of the largest trials that was done for cardiovascular disease did actually show increased death rate in patients whom the glucose was tightly controlled, because that lead to episodes of hypoglycemia or low blood sugar. So yes, we take it seriously, and that is why you have blooming of all these therapies that have been approved by FDA in the past 5 years.
Great, thank you. Can you have DPN in only one foot and not the other foot?
So I have never seen that personally,
Okay.
but is it possible? I don't know the answer to that.
Okay. Oh, another question. Sorry, they're coming in. For those who are watching who live with DPN pain, what is the benefit of participating in a clinical trial? And why is it important for people to participate in clinical trials if they're able to?
So that's a very personal question that depends on, the goals and objectives of the patients, what you've tried, what are you looking for. Certainly, if I qualify for a trial and I think that my understanding, not as a physician, but as a common man, is that it could either advance our understanding of, the current disease state, or it could help somebody down in the future, I would agree to participate. But, it is basically that you are agreeing to participate in something that might not help you, because you could be in a group that the conventional management group patients going back to the spinal cord stimulator trial did not get much benefit out of it. But at the same time, now we know the results of the trial that spinal cord stimulator does work. So it is sometimes, kind of trying to help humanity in general might not help you as a patient, but might help others down the road.
Yes.
But again,
Yeah.
it's a very personal decision. I am not advocating or telling you to go and enroll yourself in a clinical trial.
I hear you. And I think one of the things that is so interesting, at least in our community, that we hear is people are always looking to know more about trials, whether it's to participate in them or whether it's to follow the data and the research. Because at the end of the day, I think research gives us hope as a community that is looking for more options and more treatments. So thank you for that. Is there a particular order of treatments usually used to treat DPN? So for instance, starting with one class of treatment before trying the next. And then I guess the follow-up to this question that they're asking is what type of providers are best to work with to choose those and implement that? And I think you answered the first part of, or the last part of that question already, but is there a particular order that individuals should follow when looking to treat DPN?
So it's a good question. It depends on the comorbidities. That is why,
Okay.
especially pain physician who's very well accustomed to evaluating patients with diabetes and what are the options, because these are medications that are more commonly used by the pain providers. Like spinal cord stimulators are something that probably only the pain providers put in. So it is best to reach out to somebody who has all the options and to talk about options before deciding on one. In terms of the order, there is no particular order, but we try to do least invasive to most invasive. Spinal cord stimulators are an attractive option, but there is a risk of infection that, infection in the spine can actually worsen the condition. And the risk quoted in literature is 6%, so it's not that low. Again, there's an implant or hardware or, metal going inside the spine. So we have to be careful that we have vetted all the comorbidities, like smoking is a big one. Some of the societies recommend against implanting. In our practice, we don't implant spinal cord stimulators if the patient is smoking. So there are nuances to every therapy. In general, if you were to ask me, I would try the capsaicin 8% patch because the risk benefit ratio is more in favor of the benefit, excuse me, as compared to the risk, and start with an oral, medication, which is FDA approved, and then go from there.
Okay, thank you. I think we have time for maybe one more question, and I'm going to end sort of on self-management. One of the things US Pain Foundation really focuses in on is how do we build our own toolbox and incorporate a lot of different strategies, coping skills, treatment options to help improve our quality of life. And so this question was, can you discuss how self-management plays a role in both treating and potentially preventing DPN?
So that's a very good question, right? Again, there is not much in terms of prevention in literature. Maintaining a healthy lifestyle, take care of your feet. That is very, very, very important. That probably is the most important thing, along with reasonable control of blood sugar, maintaining, limiting stress in today's world. It is not possible to eliminate it. We all face it. And so, managing it best to your best ability, take a good night's sleep, eat healthy. Those are kind of the things which point to the global health. And specifically in terms of DPN, exercise and reasonable sugar control.
Well, great. Well, thank you so much. I am so sorry that we could not get to everybody's question today. I just want to put up our last slide. So first and foremost, I just want to extend my gratitude to you again, Dr. Singla, for your expertise, your insights, and everything you shared with us today. It was so robust and really looked at the full scope of how to manage DPN, but also really better understanding of diabetic peripheral neuropathy as a whole. So thank you very much for being part of this discussion tonight. To our audience who is here, thank you so much for attending. We really hope this information is going to be helpful for you as you are continuing to manage and advocating for yourselves along your own DPN journeys. For those of you that are looking for more information on how to get involved this November and learning more about diabetic peripheral nerve pain, please go to our website, uspainfoundation.org, and then you could go /November/NoDPN. So thank you all again for being here. We will make sure that this webinar is up on our website very shortly. I hope everyone has a lovely night and take care. Thank you.